Good day and welcome to the AIUM 2021 Canon Solutions Showcase, taking place here in our Canon Medical studios in Irvine, California. Liver disease is an ongoing problem, and ultrasound is at the forefront in its capability to provide a potentially faster, easier, non-invasive assessment. Today, we'll be exploring new tools in the battle against fatty liver disease, focusing on quantitative tools that may aid your diagnosis and monitoring of patients with liver disease as part of an overall assessment of the liver. I'm Dan Skyba, Managing Director of the Ultrasound Business Unit at Canon Medical Systems USA. We're proud sponsors of the AIUM, and we thank the association for the opportunity to exhibit this week. In this Solutions Showcase, we promise a scientific, educational, and practical session that we are sure you will want to share with your colleagues interested in the evaluation of fatty liver. Today, I have the pleasure to introduce two outstanding speakers who've had the experience of working with the Canon Apleo I-Series and its liver tools. First, Dr. Todd Erpelding, our Medical Affairs Leader, will present an overview on today's clinical problem along with updates from the latest research. And then, with the help of our outstanding clinical specialist Tammy Logan, they'll demonstrate how quickly and easily Canon's suite of liver analysis tools on the Apleo I-Series can enable you to perform a non-invasive and quantitative assessment of the liver in your patients. Once you're familiar with the clinical tools, we'll introduce our keynote speaker, Dr. Richard Barr. Many of you know Dr. Barr, who's a radiologist at Southwoods Imaging, professor of radiology at the Northeastern Ohio Medical University, and the editor-in-chief of the Journal of Ultrasound and Medicine. Dr. Barr joins us today from Boardman, Ohio, and he will share with us how ultrasound technologies such as shear wave elastography have evolved from research to clinical use following the latest consensus guidance from the SRU. Further, Dr. Barr will tell you about the next generation of ultrasound technologies, unique features such as attenuation imaging and shear wave dispersion, and his personal experience on how those technologies on the Canon Apleo imaging systems can be applied in your evaluation of fatty liver today. So thank you in advance for your attention. If you have questions during the showcase, please enter them in the text chat at any time, or you can hold them until the end of the program, where we'll transition to a live question and answer session with our esteemed speakers and get to as many of your questions as possible. Now let's head over to Studio B, where we'll have Dr. Erpelding ready to present. Take it away, Todd.
Hello and welcome. I'm Todd Erpelding, Medical Affairs Leader at Canon Medical, and I'm here today with my colleague, Tammy Logan. We're going to show you the liver analysis package on the Canon Apleo i800, our ultra-premium ultrasound system with outstanding workflow, ergonomics, and innovative imaging technologies. Liver disease has become a global burden and a major health concern. In fact, more than 80 million Americans are afflicted with some form of chronic liver disease. Many of these patients have viral liver diseases like hepatitis B or C, or fatty liver disease. The growth of fatty liver disease, particularly non-alcoholic fatty liver disease, or NAFLD, is especially alarming. That growth is being driven by the increasing prevalence of obesity and type 2 diabetes. The management of fatty liver disease is a clinical challenge, as it can be a slowly progressing disease with various clinical factors involved, from steatosis, inflammation, fibrosis, and cirrhosis. Patients may require long follow-up, and the current standard of care for assessment of liver disease is often biopsy, a painful and invasive procedure. Clinicians and patients need better options. A non-invasive, validated, and economical test that can be used in early detection, staging, and therapy monitoring of liver disease is clearly needed. Let me tell you a little bit more about the Apleo I-Series liver analysis package. When you look at the progression of NAFLD, the earliest stages start with fatty infiltration or simple steatosis, which often goes undetected. Some patients are at risk for inflammation and fibrosis, leading to a more advanced stage of fatty liver disease called non-alcoholic steatohepatitis, or NASH, which can involve liver cirrhosis and perhaps liver cancer. For patients at risk of liver cancer, contrast-enhanced ultrasound can be useful for the characterization of liver lesions. With the Apleo I-Series, we also offer a robust quantification software to quantify the time intensity curve from microbubble contrast agent accumulation within focal liver lesions. For liver fibrosis or cirrhosis, shear wave elastography can be a useful non-invasive tool for accurate and reproducible assessment of fibrosis in patients with liver disease. But for the earlier stages of liver disease, particularly steatosis and inflammation, ultrasound has lacked the diagnostic capabilities for quantitative assessment. That's where Canon's unique suite of liver analysis tools, including not just shear wave elastography, but shear wave dispersion and attenuation imaging, that can be used as an aid in the diagnosis and monitoring of patients with NAFLD and NASH. Shear wave dispersion, Canon's unique enhancement of conventional shear wave, displays and quantifies the shear wave dispersion slope, which is related to liver viscosity. Recent studies suggest that the dispersion slope can help provide a quantitative, non-invasive assessment of lobular inflammation in patients with NAFLD and NASH. Last but not least is our attenuation imaging, which is a reliable and accurate tool for the assessment of hepatic steatosis. It's well understood that a fatty liver is more attenuating, and now clinicians have an imaging method to detect and quantify attenuation in patients with steatosis. Now let's take a closer look at some recent clinical studies that reported on the use of Canon's liver analysis tools. Here I'm showing results from 2 independent studies that included more than 200 patients suspected of NAFLD or NASH. All patients underwent quantitative ultrasound exam with the Canon Apleo i800, immediately followed by liver biopsy for the diagnosis of NASH. All liver biopsies and ultrasound exams were performed on the same day in both of these studies. Based on area under the ROC curve, or AUC, results were generally good to excellent in the diagnostic performance for the use of shear wave speed and detecting fibrosis grade, attenuation coefficient for detecting steatosis grade, and shear wave dispersion slope for detecting lobular inflammation. These results are certainly promising and suggest that Canon's liver analysis tools may reduce the need for liver biopsy in patients suspected of NAFLD by helping to identify patients at risk for NASH. So let's move to the Apleo i800 system and look at some live scanning. While scanning today, Tammy will be using an ultra-wideband matrix array transducer, the i8CX1. This transducer utilizes Canon's intelligent dynamic microslice, or IDMS matrix technology, to control the firing of individual transducer elements in the lens direction, which creates a thin slice beam giving great detail from skin line to the far field. So let's start with liver shear wave. To begin, the patient should be placed in a supine or slight left lateral decubitus position with the right arm reached over the head. We'll be scanning the right lobe of the liver in an intercostal acoustic window, taking care to avoid shadow artifacts and large vessels in the portal trunk. Once you've found a good window, the shear wave function is easily launched by pressing the SWE button from the touchscreen. The shear wave ROI appears outlined in green and should be placed in the center of the image, approximately 1 centimeter below the liver capsule. Now when you're ready to acquire, ask the patient to suspend breathing mid-respiration and press the one-shot button next to the trackball. As you can see, the measurement ROI automatically appears, and the shear wave speed and propagation map are displayed in twin view. On the left-hand side is the shear wave speed map, and you can see in this patient that the deep blue colors indicating a slow shear wave speed in meters per second, which is consistent with the patient with a normal healthy liver. On the right-hand side is our propagation map, and that's Canon's unique offering to help assess the quality of the shear wave acquisition and help guide the placement of your measurement sample. Look for smooth, parallel propagation lines when setting your ROI. When the image is stored, the measurement result is automatically entered into the shear wave worksheet. Now let's take a look at some recent clinical studies that demonstrate how Canon's shear wave elastography can be a useful non-invasive tool for accurate and reproducible assessment of hepatic fibrosis in patients with liver disease. The studies presented here include patients with various liver disease etiologies, with the majority of patients having had NAFLD or viral hepatitis. In these studies, liver biopsy or transient elastography was used as the reference standard for hepatic fibrosis assessment. As you can see, the diagnostic performance of shear wave elastography for the detection of liver fibrosis was good to excellent, based on an AUC of greater than 0.8 for significant fibrosis F2, severe fibrosis F3, and cirrhosis F4. The corresponding shear wave cutoffs for the stages of fibrosis from the previous studies are presented here. As expected, higher shear wave values were consistent with more advanced liver fibrosis. In general, the detection of significant fibrosis, or F2, was reported with a cutoff of approximately 7 kilopascal, and the detection of severe fibrosis, or F3, was reported with a cutoff of approximately 9 kilopascal, although some overlap of cutoff values between the studies was observed. Recently, the Society of Radiologists in Ultrasound, or SRU, released an updated consensus statement on liver elastography. A new recommendation known as the Rule of 4 was introduced for interpretation of liver stiffness in patients with viral hepatitis and NAFLD. The Rule of 4 focuses on the detection of compensated advanced chronic liver disease based on cutoffs of 5, 9, and 13 kilopascal. A liver stiffness of less than 9 kilopascal rules out compensated advanced chronic liver disease in the absence of other known clinical signs. A liver stiffness of greater than 13 kilopascal rules in compensated advanced chronic liver disease. A liver stiffness in between 9 and 13 kilopascal is suggestive of compensated advanced chronic liver disease, but further testing may be appropriate. As you can see, there's good agreement between the SRU Rule of 4 and the previous studies with Canon shear wave elastography. Next, we'd like to show you attenuation imaging. Conventional methods for ultrasound assessment of hepatic steatosis are largely qualitative and subjective, such as comparing the brightness of liver and kidney. With attenuation imaging, we have a reliable and accurate tool for the assessment of liver steatosis that is real-time, fast, and easy to use. Recent studies have shown that the attenuation coefficient can be a valuable biomarker for detecting and quantifying liver steatosis, including mild steatosis, as compared to histopathology or MRI proton density fat fraction, PDFF. Let's take a closer look. A number of published studies have reported on the use of Canon's attenuation imaging for the detection of liver steatosis, including more than 775 patients. In these studies, histopathology from liver biopsy or MRI PDFF were used as the reference standard for steatosis grading. Generally good to excellent diagnostic performance for detection of mild steatosis S1, moderate steatosis S2, and severe steatosis S3 were reported based on AUC results. The corresponding attenuation coefficient cutoff values for detecting S1, S2, and S3 liver steatosis grades are presented here. A good agreement between these studies is observed for detecting moderate steatosis, or S2, based on an attenuation coefficient of 0.7 or 0.72 dB per centimeter megahertz. Further studies of attenuation imaging are ongoing. Let's take a look at how this works. As you can see, attenuation imaging is a real-time imaging mode, and it can be displayed in twin view. It displays and quantifies the attenuation coefficient in units of dB per centimeter megahertz. Scan the right lobe of the liver with an intercostal window, just as we demonstrated with shear wave. On the left is your conventional grayscale image, and on the right is the attenuation color map overlaid on the grayscale image. Orange indicates higher attenuation coefficients, and the greens and the blues indicate areas with lower attenuation coefficient. Vessels and echogenic structures are automatically excluded from the color map, enabling you to easily assess the liver parenchyma. When you're ready to quantify the attenuation imaging results, simply press the freeze button, and your measurement ROI box will automatically appear. Place the measurement sample avoiding large vessels, artifacts in the subcapsular region, and areas of weak signal. Attenuation imaging can be performed quickly and easily, often only needing 1 to 2 minutes to complete your assessment for liver steatosis. Thanks, Tammy. So at Canon, we recognize that sonographers are often challenged by doing more exams in less time, and workflow is becoming increasingly important. For the quantitative liver analysis tools, we've created a streamlined workflow that allows for simultaneous acquisition of shear wave elastography, shear wave dispersion, and attenuation imaging results. Let's take a look at how it works. We've incorporated this simultaneous capture and quantification of all three liver analysis parameters into our conventional shear wave elastography mode. As we showed before, when you launch shear wave elastography, you'll place your green ROI appropriately in the right lobe of the liver. Now, when Tammy acquires her shear wave result with our one-shot acquisition, you can display the shear wave speed map side by side with the attenuation imaging result, giving clinicians the ability to assess hepatic fibrosis and steatosis in a single view. We've also taken it one step further with our quad view display, which can show shear wave speed, attenuation imaging, and shear wave dispersion results simultaneously alongside the propagation map. Now clinicians can quantify all three parameters in a single acquisition with an optimized workflow. Now let's take a look at how we summarize the quantitative liver analysis results. Here's our multi-parametric report, which provides a concise summary of all your liver analysis results: shear wave elastography and shear wave dispersion, attenuation imaging, and the associated statistical values like median and IQR to median ratio. In the upper right corner, we have our unique slider display. So the current patient results can be displayed on a customized scale, which can be adapted based on the latest published studies and guidelines, including the recent Rule of 4 recommendation from the Society of Radiologists in Ultrasound, or SRU, which highlights the current best practices for interpretation of liver stiffness in patients with viral hepatitis and NAFLD. With the multi-parametric report, you can quickly see where the current patient's shear wave results lie in terms of the Rule of 4 on a scale of 5, 9, 13, and 17 kPa. The multi-parametric report can also be customized to incorporate clinical information, such as BMI or lab values, for a more comprehensive assessment of the patient's liver health in a simple and concise snapshot. Here, as you can see, we've added the AST and ALT lab values to the multi-parametric report, and those can be displayed at the same time as your quantitative imaging findings for shear wave dispersion, and attenuation imaging. So I hope you've enjoyed today's demonstration of Canon's liver analysis package. The power of the Apleo I-Series platform enables a streamlined workflow for getting additional quantitative information so you can better assess the liver health in patients with chronic liver disease. Now it's my pleasure to turn the presentation over to Dr. Richard Barr. He'll be presenting a lecture entitled Evolving Trends in Quantitative Ultrasound for Chronic Liver Disease. Dr. Barr, thank you for joining us here today.
Thanks, Dan and Todd, and I want to thank Canon for letting me share my experience with the Canon Apleo system for the evaluation of chronic liver disease. So, chronic liver disease can be caused by many etiologies. The most common are hepatitis C and hepatitis B. We now have reasonable drugs and cures for these, and they're becoming less and less prominent in the United States. Non-alcoholic fatty liver disease and NASH, the spectrum of fatty liver disease, is now our major health problem that we have to deal with, and we're going to focus a lot on how we can use these new technologies to make this diagnosis in a quick, non-invasive way. And if we're going to assess chronic liver disease, we need to know what is the degree of liver fibrosis, what is the degree of inflammation, and what is the degree of steatosis. And we'll go through these. In the past, we did a liver biopsy to assess all these. Until recently, we couldn't do this with ultrasound, but now with modern technology, we can begin to evaluate all of these techniques in a non-invasive way, and we can do this over time, so a patient does not have to have multiple liver biopsies. Let's start with liver fibrosis. Liver stiffness can be assessed by shear wave elastography. Liver stiffness is affected by fibrosis, inflammation, and congestion. So therefore, there are confounding factors in the shear wave assessment of liver fibrosis: inflammation, congestion, which essentially increased right heart pressure, increased portal vein after we eat, respiration, either taking deep inspirations or expirations, extrahepatic cholecystasis, as well as technical factors including steatosis. And we don't have time to go over all of these, but Dr. Ferrioli is giving a talk on the SRU updates at this meeting, and I'm sure she's going to go over all of those. That would be a good talk for you to listen to understand all the complicating features of assessing liver fibrosis. So this is from the SRU consensus in 2015 that was published in Radiology. It summarizes all the issues that we feel that need to be addressed when we're assessing liver stiffness. We have pre-test and post-test probability. What is the incidence of the disease in the population we're looking at? All these different diseases in the funnel that all lead to fibrosis and on to cirrhosis. Age, gender, ethnicity, and lab tests may affect our results. Patient factors such as obesity, ascites, medications, and fasting can affect our results. Comorbidities, acute on chronic disease and vascular congestion will affect our results. And the method of performing elastography. We now have MR and ultrasound methods, and we have different ultrasound methods with different hardware and software. And obviously the experience of the person interpreting and doing the exam is also very critical. This is something that was from the SRU consensus in 2015. And basically what we did is take a large meta-analysis, and what we did was plot out for a given shear wave speed what was the probability of a METAVAR score. And you'll notice from this graph that we do pretty well in pretty normals, F0s and F1s, and we do really well with people that have F3 and F4, which we're now going to call compensated advanced chronic liver disease, but we have this middle range where there's an overlap of many different scores. So the SRU initially decided to give a low cutoff value below which you either had no or mild fibrosis, a high cutoff value where you had severe fibrosis or cirrhosis, and then the middle degree where you had moderate fibrosis. The Bevino 6 conference at about the same time gave these following guidelines, and it was meant for transient elastography or FibroScan. Less than 10 kPa in the absence of other known clinical signs rules out compensated advanced chronic liver disease. Values between 10 and 15 kilopascals are suggestive of compensated advanced chronic liver disease, but need further tests for confirmation. Values greater than 15 kilopascals are highly suggestive of compensated advanced chronic liver disease, and values equal to or greater than 20 to 25 kilopascals can rule in clinically significant portal hypertension. Dr. Ferrioli was the lead author in the World Federation of Ultrasound and Medicine and Biology guidelines that were published in 2008, and we came up with the rule of 5. 5 kP or less, normal. Between 5 and 10, small chance, and clinical signs, you need to do a test to rule out compensated advanced chronic liver disease. Between 10 and 15 kilopascals, there is a moderate probability of compensated advanced chronic liver disease, so you should do a test to rule it in. Above 15 kilopascals rules in compensated advanced chronic liver disease, and we chose 20 kilopascals to rule out varices needing treatment. So both the WFM and SRU guidelines recommend not using METAVAR cutoff values, and I think this is now consistent even in the hepatology literature. We're finding as we're using these techniques that what's really important is compensated advanced chronic liver disease, F3 and F4. These patients are all at risk for the complications of chronic liver disease, including development of hepatocellular carcinoma, portal hypertension, and varices. And because of the overlap of liver stiffness values between METAVAR scores is as large, if not larger, than the difference between vendors, the updated SRU says separate cutoff values for each vendor are not recommended. That does mean each vendor will have their own sensitivity and specificity, but this significantly makes the interpretation a lot easier. So these are the new guidelines that were published in Radiology in April of 2020 from the SRU. So less than 5 kilopascals, which corresponds to less than 1.3 meters per second, high probability of being normal. Less than 9 kilopascals or 1.7 meters per second rules out compensated advanced chronic liver disease in the absence of other known clinical signs, and if there are known clinical signs, may need further testing for confirmation. Between 9 and 13 kilopascals, suggestive of compensated advanced chronic liver disease, but need further testing for confirmation. Above 13 kilopascals, rules in compensated advanced chronic liver disease, and above 17 kilopascals or 2.4 meters per second is suggestive of clinically significant portal hypertension. So we call this the rule of 4, starting at 5. And if we look at the data from the Canon system, you can see that we actually have fairly good agreement with the SRU guidelines. So less than 5 kilopascals, almost all are F0 or maybe even F1. Above 13 kilopascals, everybody is for the most part F4. And above 9 kilopascals, most people are in this zone where there are a fair amount of people with compensated advanced chronic liver disease, but there's still some that don't have it. So again, this is why we recommend doing an additional test. So again, here we put the cutoff values for the SRU. Below this value, all F0s and F1s. Between 5 and 9, mostly F1s and F2s. Above 9, again, a fair number of F3s and F4s, compensated advanced chronic liver disease, but there still can be several patients that do not have compensated advanced chronic liver disease. So that's why we ask for another test to rule it in or rule it out. And above 13 kilopascals, everyone does have clinically compensated advanced chronic liver disease. So here are just some examples of images from the Canon system. On the right, we have the propagation map. It's showing you, in a sense, the shear waves moving through. And this is a quality measure because we want the shear wave, since the liver is a homogeneous tissue, we would like to see these waves being parallel. And if they're parallel, we think we've got good shear waves. On the left is our velocity map, or stiffness map, if you will. It's color-coded. Blue is soft, red is stiff. And these little red boxes tell us where the computer has analyzed the propagation map and tells us where we have good data. So here we can put our ROI, and here we can come up with our average stiffness value and other information. And this patient, the average value after 5 measurements was 4.2 kilopascals, or 1.19 meters per second, which is normal. This case, less than 9, where we want to rule out compensated advanced chronic liver disease. Again, we can see the waves. We pick an area, again, that's pretty parallel. And in the velocity map, you can see we've got a lot of red squares, a lot of choices of where we can put our ROI. Again, looking at the propagation map, we selected this area. And here we came up with a median shear wave elastography value of 7.9 kilopascals for the 5 measurements, which corresponds to 1.62. Going between the 9 to 13, which is suggestive of compensated advanced chronic liver disease. Again, we have the the propagation map. You'll notice that the waves are now getting farther apart. That's because the shear waves are moving faster. Again, we look at the red box, and here we chose this area. And again, the average of our 5 measurements was 11.3 kilopascals, or 1.94 meters per second. And again, looking at a case above 13 kilopascals, ruling in compensated advanced chronic liver disease. Again, notice on the propagation map that the distance between each of these waves is much larger, showing that the shear waves are moving faster. Again, we chose an area within the red boxes that tell us where the quality measure is. And here we come up with a median of 13.1 after our 5 measurements, or 2.09 meters per second. The SRU new guidelines say to follow up patients, the consensus suggests that using the delta change of liver stiffness over time instead of the absolute value, using as baseline value in the case of viral hepatitis, that obtained after viral eradication or suppression. Now, I will add that it is actually not a bad idea to do a measurement before you start treating patients with hepatitis B or hepatitis C. And the reason is, if they do have compensated advanced chronic liver disease before treatment, after the treatment, even if it looks like they have a complete cure, they are still at higher risk for the complications of chronic liver disease, including the development of hepatocellular carcinoma. So they do need to be screened every 6 months looking for masses. For pediatric patients with liver disease associated with cystic fibrosis, autoimmune hepatitis, biliary atresia, and the Kasaki procedure, or congenital heart disease with Fontan surgery, it is expert opinion that each subject becomes his or her own control, using the stiffness delta change over time to evaluate the efficacy of the treatment or progression of disease. And remember, particularly in those patients with Fontan, that right heart pressure is going to affect these measurements. So you try to do the measurements and the patient has in the same cardiac status so you can really assess the fibrosis. If the congestive heart failure is changing, it will affect the measurements and you will not be able to get an accurate reading of the degree of fibrosis. As of January 1st, 2019, we have a CPT code category 3, a billable code, 76981, ultrasound, elastography, parenchyma, meaning an organ. Global charge is $109.56. The technical component is 80.25, and the professional component is 29.31. So we are getting reimbursed, and I will say that I, over the last year, looked, and we are getting actually reasonable reimbursement. In fact, I think that our overall reimbursement for these was about $85, and we have a large amount of Medicare cases. So denials were only in Medicaid and some of the supplemental policies with Medicare, but for the vast majority of these cases, we're getting billed. And I think what's really important here is you can also bill for your ultrasound abdomen limited or a complete study if you do them at the same time. Before this code, there was a code that began with 9 that was meant for transient elastography that you could not bill for an ultrasound of the abdomen and an elastography on the same day. So now with this new code, you can do that. So let's move on to steatosis assessment. So NAFLD-NASH, or the spectrum of fatty liver disease, is now our major issue for chronic liver disease in North America, as we now have excellent treatments for hepatitis B and hepatitis C, and they are now at a very reasonable cost. So most insurance companies are paying for treatment of everyone. A couple years ago, we were doing a lot of our liver elastography to assess the degree of fibrosis to determine if the insurance companies would pay for treatment, and we're finding that that's no longer the situation. NASH can progress to compensated advanced chronic liver disease with its complications, and the assessment of the degree of steatosis is critical for the diagnosis of NAFLD, non-alcoholic fatty liver disease. So a method that can assess changes with treatment is required. Presently, only biopsy and PDFF by MRI are documented to meet these requirements. So an ultrasound method of steatosis assessment would be clinically useful, as it is quick and simple and easy to do and can be repeated so we can watch the progression of patients' disease. And then this now brings up a new problem of what is the gold standard? Do we rely on liver biopsy or do we use PDFF? And since PDFF is now available in many centers, we feel that this is the most appropriate gold standard, as many patients do not want to do liver biopsy, and we get skewing of results because people that probably don't have high degrees of steatosis are not sent for biopsy. So there's a bias in who gets selected for doing a liver biopsy. I'm sure you're all aware in the United States, about 40% of adults are obese, 19% of children are obese. We have over 100 million people affected with fatty liver disease, and these people are 1.65 times more likely to have significant undiagnosed conditions. And obesity is linked to more than 60 chronic diseases, and $190 billion of medical care in 2005 was related to obesity, and that is only increasing. It's important to make this diagnosis of NAFLD where we have greater than 5% fat in the liver, so patients can be treated and are followed. And the attenuation coefficient using ATI is available to detect the degree of stenosis and make the diagnosis. Present diagnosis of NASH is difficult without a biopsy. Increased liver fibrosis and abnormal enzymes can interfere with the diagnosis. 6% of all NAFLD patients have cirrhosis. These are probably miss cases of NASH, and 10% of NASH patients will have cirrhosis based on an autopsy study of 1990. 1/3 of patients may be expected to show progression of fibrosis over a 5 to 10 year period. With the viral hepatitis, these progress usually over 20 to 30 years, so there's a faster progression of NAFLD than the viral hepatitises. Diabetes, obesity, and insulin resistance stands out as risk factors for progression, and I will add that those patients that actually have NAFLD are actually at a higher risk for cardiovascular events than they are for complications from their liver disease. So addition of statins to these patients is a prudent measure. And NASH is predicted, if it hasn't already, to become the leading cause of liver transplant in North America. If we look at the results of the attenuation imaging, again using ATI technology and the calculating the attenuation coefficient, these are the results from 5 studies that have been published using either a combination of PDFF or biopsy. And you can see that values of about 0.6 or less or S0 normal, values of about 0.7 to 0.6 or S1, values between maybe 0.7 and 0.75 or S2, and values above 7.5 or S3. So there's a little overlap between these studies, but not much. And I think, again, it's important to remember that we can follow these patients serially with time, and it's the delta change that may be important, as we see with liver fibrosis. And that's yet to be determined, but that's an assumption I think we can make. So let's revisit this case that I showed you before with the less than 9 kPa. In this case, the median shear wave speed was 7.9 kilopascals. So again, below 9 in the absence of clinical significant findings, rules out compensated advanced chronic liver disease. But what we do now here is the ATI image. So what we have is large field of view box. The yellow box is what we're using to measure the attenuation. And it comes out to 0.88, and we talked about above 0.75 was S3. So this is an extremely fatty liver. So we do know that this patient has a very steatotic liver and slightly elevated liver stiffness. And one thing I wanted to point out here was that we have this R squared number. So this is kind of a confidence number. It tells us what the quality of the measurement in this yellow box is, and we want that value to be above 0.9. So again, some portion of NAFLD patients are going to progress to NASH, and when I looked in the literature, it's somewhere between 6 and 13%. And of these NASH patients, 9 to 20 will progress to cryptogenic cirrhosis, 26 to 37% will progress to fibrosis, 52 to 79% will be stable or have regression of fibrosis. So of the patients which progress to cryptogenic cirrhosis, 40 to 60% will progress to cirrhosis-related complications, including hepatocellular carcinoma, again, over a relatively short period of time compared to the viral hepatitis, 5 to 7 year period. The next component that we need to do to really assess chronic liver disease is inflammation. And inflammation is a confounding factor in the assessment of liver fibrosis using shear wave elastography. It increases the value. And again, remember, we measure liver stiffness. We don't measure liver fibrosis. And liver stiffness is a combination of fibrosis, congestion, and inflammation. The inflammation is indicative of acute disease. And we know from the literature that if the patient's liver enzymes are greater than 5 times the upper limits of normal, that it's almost impossible for us to calculate an accurate liver stiffness value. The detection and quantification of inflammation would add to the diagnosis, management, and follow-up of patients with chronic liver disease. In particular, it may be able to make the diagnosis of NASH in patients with non-alcoholic fatty liver disease, and shear wave dispersion imaging may provide this information. And what is shear wave dispersion imaging? So until recently, what we've been doing is we have calculate the shear wave speed at a fixed RF frequency. And dispersion is how does that value change when we change the RF frequency. So we're now going to do multiple measurements at different RFE frequencies, and we're going to see how that changes. And if we have inflammation or viscosity, that is going to change a lot more. So now if we look at the Canon system, with one button, push of the button, we can get the shear wave speed, a surrogate for liver fibrosis. We have the propagation map that shows us that we've got the shear waves moving in a nice pattern. We've got attenuation imaging, which is now telling us the degree of steatosis. And we now have dispersion imaging, which we're hoping, in early literature suggests that it may relate to inflammation. And we need some more work on this. But again, it's very intriguing and may be very helpful. So now when we look at our report page from the Canon system, here we did 10 measurements of shear wave. We did attenuation in 5. We did dispersion in 10. And we get these little sliding scales that go from normal to grossly abnormal. So kind of blue and green are in the normal range. Yellow is elevated. Orange, we're in the intermediate to high range. And then red, obviously, we're maxed out. So again, if we're using the rule of 4 here, this patient is between 5 and 9. It looks like it's about, we could actually look to see what it is. It's about 1.5 meters per second, which is 6.6, about 7 kilopascal. So again, in the absence of other factors, we would consider this to be unlikely to have compensated advanced chronic liver disease or NASH. So I just wanted to go over my experience using the Canon Apleo i800 system in our outpatient private practice. Here are some cases. This is a 60-year-old female that we did 1 year prior. At that time, her stiffness value was 5 kilopascals normal, 1.3 meters per second. So she comes back a year later, and now her liver stiffness is 10.3 kilopascals. If we look at the propagation map, we have really nice parallel lines. They are fairly far apart, again suggesting that we probably got fast shear waves, again placing the ROI box in an area that the computer has decided we got good measurements. Again, we come up with 10.3 kilopascals. This is the dispersion. We're not going to talk about that right now. But if we look at the attenuation imaging, you'll notice we got an R squared of 0.98, a very good measurement. And it's 0.91, and we said anything above 0.75 is S3. So this is S3. I do want to point out, you may see this orange in some of these. This is a reverberation artifact, same artifact kind of that we see when we're doing liver stiffness. So you don't want to place your box in that area because the reverberation artifact does give higher values of attenuation. So now when we look at this patient, she has significant fatty liver disease with an ATI of 0.89. Her liver stiffness is now 10.3, above 9 kilopascals, and she has very high dispersion. And again, we can look at our color maps here, and we can see again shear wave speed getting up kind of high, shear wave dispersion very high, suggesting possible inflammation, and a fatty liver at the S3 level. So this patient, we now know, because we have very fatty liver, we have above 9 kilopascals, and we have a high dispersion, this patient has a very high probability of doing NASH. And if the SRU consensus from the 2020 suggested that above 9 kilopascals in a patient with non-alcoholic fatty liver disease is highly suggestive of NASH. And there are now reports that some patients between 7 and 9 kilopascals may have NASH. So we report out between 7 and 9, NASH should be considered. So again, here is her attenuation. Again, remember when you see this orange, please ignore it. That is, again, artifact from reverberation. Again, here we get 0.99, a very good quality measure, and again, 0.82. Actually, this was another patient, a fatty liver with a 0.8, again, S3. But when we look at their shear wave speed, it's 1.3 meters per second, which is 5.2 kilopascals, basically normal. And we got a dispersion down in the low range also. So in this patient who had a fatty liver very similar to the first patient we discussed, there's no evidence for NASH. So we can clearly make these differentiations And again, I think these are very helpful, and it's able to follow patients, as I showed you in the first case, where we see those dramatic changes over the course of a year. So we did a workflow study using the Canon Apleo system for chronic liver disease. I looked at 110 consecutive patients. These were patients that were brought into our difficult room. So they are the difficult patients. They were scanned either by less experienced sonographers, less than 1 year of performing liver elastography, or more experienced, greater than 2 years of performing liver elastography. All exams were performed according to the SRU guidelines. We collected both the shear wave elastography, the dispersion, and the ATI. We measured the time duration of the study, the IQRs over median, the thickness of the skin to the liver capsule as a surrogate for BMI, and the depth to the center of the ROI box, which is, I think, a very important measurement for us to look at. So again, these were patients that were assigned to this room because they were difficult. So on looking at these patients, they looked like they were going to be difficult patients where we were going to have a problem because of high BMI. And this is shown out that the mean liver to the mean skin to liver capsule distance was 2.6 centimeters, ranging from 1.6 to 5.8 centimeters. And if we look at the distance to the center of the ROI box, it was 6.1 centimeters as an average, ranging from 4.1 to 8.6. And again, we know that the ideal location for accurate liver stiffness measurements is 4 to 4.5 centimeters from the skin. And that this confirms that these were difficult patients because we had to stay outside of the reverberation artifact. And the mean ATI of these patients was S2. And if we look at the mean time to do the examination, was about 130 seconds, so about 2.5 minutes to collect all the data for a complete chronic liver disease evaluation. The range was from 46 seconds, so less than a minute, to up to 5 minutes. The less experienced sonographers took a little bit more time than the experienced sonographers. That really was not that significantly difficult, significantly different. And if we look at the IQs, the average was 13.3. Again, we'd like measurements below 15%. We did range from 1 to 36%, so there were some patients that were, we couldn't get a really good IQR over median. Interesting enough, here the less experienced sonographers had a lower value that was significantly significant. And I think the reason for this was, again, they evaluated the patient as they were walking in, and I think the less experienced sonographers ran the other way, made the more experienced sonographer do those cases. If we look at, we had 14 cases of the 110, or 12.7%, that the IQR over median was greater than 15%, but 7 of those cases was between 6 and 18, and there was maybe one measurement that it was a little out of whack. And we had 5 cases that were greater than 20%. So we have something on the order of about 3 to 5%, I think, that we were not able to feel really confident that we were giving a good value. And I think that's consistent with what other people are finding. If we looked at the dispersion, the mean was 12.7, and it ranged from 7.7 to 27, quite a range. Again, the IQR over median here was much larger, and there was much more variability in the IQR than in liver stiffness values. If we looked at the attenuation imaging, the ATI was about 0.6, somewhere in the S2 range, again ranging from 0.35 to 0.98. The mean IQR was about 14.7, again ranging from a very low 0.2 to up to 55% in some of the difficult cases. And again, if you look at the mean R squared value, here you can see some examples where it's in red, meaning stop, don't believe this measurement, because the IQR is less than 0.9, 0.67. And you can see why there are many areas here that don't fill with color, saying that there's artifacts. Yellow, meaning caution, try not to use this measurement unless you have to. Again, less than 0.9, 0.85. And again, you can see we've got some artifacts in this measurement. And again, a white, meaning we've got a good measurement, R squared of greater than 0.9, in this case 0.99. There really was no correlation between the values of IQR over median for shear wave speed, shear wave dispersion, and ATI, suggesting that these parameters may be independent of each other as we collect them, even though we're collecting them all with one push. So to conclude, the assessment of liver stiffness has matured, although still has complicating features. Evaluation of hepatitis B, hepatitis C, and NAFLD are better understood. Further work is needed in other etiologies. The new SRU guidelines simplify interpretation. And again, Dr. Ferrioli is giving a talk at the meeting here on the SRU updated guidelines. I recommend that you listen to her talk. A quantitative ultrasound assessment of chronic liver disease can be obtained in less than 3 minutes. ATI can help distinguish and monitor patients with NAFLD and NASH by providing a quantitative assessment of liver steatosis. Canon's liver analysis features, including shear wave elastography and ATI, may help to identify NAFLD patients at risk for developing NASH. Early work suggests that shear wave dispersion may be helpful in assessment of inflammation, and this again would be extremely helpful in the assessment of chronic liver disease, particularly in NASH and alcoholic chronic liver disease, although further study is needed, as this was the technique that's actually relatively recent and we don't have a lot of literature. So I hope this has given you a nice overview of ultrasound for evaluation of chronic liver disease. We are making a lot of progress in getting an ability within, again, in 3 minutes to do a very good qualitative assessment of chronic liver disease and follow these patients in a non-invasive way as many times as we want. Eliminating the need for biopsy and maybe eliminating the high cost of having to do multiple MRIs. So I hope that's helped. And if you have any questions, Dan, Todd, and I will be here now to answer any questions you may have. And again, I want to thank Canon for inviting me to give this talk.